Okay, there we go. Good evening, everyone. It is Wednesday evening and we are live and we're just waiting for a few people to join us. It is trying to conceive. Our topic this evening is trying to conceive with fibroids. So I know there's a lot of women that actually suffer from fibroids. And tonight we've got Dr. Moloi. He's from the Joburg Fertility Centre. We've had him on before. And yeah, I know lots of the women love listening to Dr. Moloi. And I've got quite a few questions to ask him. So we're just going to give him a couple of minutes for him to join us. And yeah, so trying to conceive with fibroids. If you have fibroids, if you have any questions, please, guys, send us a little comment. Put any question relating to trying to conceive. Please put your comment in the comment section, and I will ask Dr. Moloi at the end of our talk. So as I said, I'm just waiting for Dr. Moloi to come on, and yeah, so just give him a couple of minutes. Here we go. So do you have any? Hi Shanae, hi Missy, Lepuru, Rachel, Kate, Sheila. I see the food company joined. I don't know what your name is, sorry. So just send me a little message in the comment section if you guys have any questions relating to trying to conceive, and especially if you're suffering with fibroids, let us know what it's like. Is it painful? Do you have any advice that you can share with anyone else? I'm just going to wait for Dr. Moloi. If you, as soon as you get on, please send me a message. So just send me there we go. Dr. Moloi is here. And hi, Dr. Moloi. Just send me a little request to join, and I'll actually wait for go. And just hoping we wait for Dr. Moloi to join now. Here we go. Hi, Claudia. Nice to have you. Dr. Moloi, how are you?
I'm okay, and you, ma'am?
I'm good. Thank you, Dr. Moloi. Nice to have you join us again.
Yeah.
Good.
After a long time.
Yes, it's been a long time. So, Dr. Moloi, we touching on the subject of trying to conceive with fibroids. And we've got quite a few on now because I think it's quite a good topic to discuss. And there's a lot of women that actually deals with fibroids. As soon as I posted the question, like, please guys, tell me, are you dealing with fibroids? I immediately had a lot of people responding, and I've got quite a few questions for you. But first of all, maybe just want to say something, greet everybody.
Yeah. Good evening, everybody. Actually, I'm from theater. I had to, the operation of the fibroids through laparoscopy. It was interesting. I just finished now, and wow. I'm happy to join you.
Awesome. So thank you for giving up your time. I know your time is very precious. I always tell the doctor, thank you so much for giving up your time with us. Because yeah, it takes a lot out of you to even just do a couple of minutes with us, because I'm sure you're back to back. So doctor, just tell us if you guys didn't know, let me just confirm, Dr. Moloi is from the Joburg Fertility Centre. If you'd like to get hold of him, please, you can DM him. He is on Instagram. You can email me. You can email him directly to get hold of him. They've also got a website, so it's Joburg Fertility Centre.co.za. You can contact him that way. So he is a fertility specialist in the Joburg region, Gauteng area. Dr. Moloi, tell us, what is fibroids, first of all?
Yeah, basically fibroid, we classify them as benign, tumor which grow in the uterus. And then this tumor are so common, especially in African women compared to other, a nation. They present basically with three symptoms, I would say. It's heavy bleeding, pain, and most likely with infertility. Therefore, are just benign tumors, which are common in women. And I would say about 30 to even 70% of women in the reproductive age have what we call the fibroids.
Oh. Okay. Is there anything that we can do to prevent it if a woman is, she's been diagnosed with fibroids? What is it, the type of treatment that is offered for someone that has been diagnosed with fibroids?
Yeah.
Okay. Doctors,
Will be obviously not symptomatic. In other words, they'll go around and not knowing about them. Majority of them, late, they would like to have a family. Then is when we pick up the fibroids. Therefore, it's what is common in this kind of women. And then what I would say as well, it's very important that women, especially presenting early with abnormal bleeding and pain, that they should be, scanned properly so that we can find out whether they've got fibroid or not.
Okay. Yeah, doctor. So what treatment would you recommend? Is it, do you do surgery, or what type of treatment do you recommend when you're diagnosed with fibroids?
Yes, thank you for that question. Now, the important thing I said, we should actually take a proper history or evaluate the woman. If a woman really to us come with a problem of fibroid, most of the time it's because they would like to have children. Therefore, they've got difficulty perhaps to have children. Therefore, that's the biggest category of women we see with fibroid. The second category, it may be women who are over 40, but present with a heavy abnormal bleeding, but they've likely finished the family. Therefore, that's that's the second group. The third group, it will be women coming as well with a mass and a pain. And to some extent, they may have bladder symptom, they may have constipation, they may have even, painful sexual intercourse. Therefore, it's a different category. Therefore, it's very important that from the beginning, really evaluate these people and know exactly what's the problem. Now, I'll talk about the impact of fibroid basically in a woman who would like to have children, or who in future will prefer to have children. The evaluation of this is very important, that, seeing a gynae pick it up and send that patient to us. Then when we evaluate, we look at the fibroid, where is the fibroid, and how big is the fibroid. Fine? Then why we do that is very important. I'm just going to run through a classification which medically we use. The fibroid can be in the cavity, in other words, in what we call the endometrium, the inside of the womb. Then we call that submucosal fibroids. Then the fibroid can be in the muscle of the womb, that we call intramural. It can be in the cervix as well. It can be even pop out of the cervical canal, in that case causing bleeding and all that. Then you can get fibroid there. Then it can be on top of the uterus, which is, we call it subserosal. Therefore, usually the subserosal, they may be big, which, one of my patients I just operate, very huge one, but it was giving terrible pain and symptoms. And then, however, she still wanted to get pregnant on that. It's unlikely that subserosal fibroid can really cause problem with infertility, but it can. Now, the intramural, which is right in the muscle of the uterus, the size is very important. Usually, if the bigger the size or the effect on the cavity of the uterus, it's having, you can see that impact when you do the ultrasound. The uterus shape is not okay, the inside of it, and that particular fibroid need to be taken. Then there are fibroids as well in the inside, growing in the cavity. The reason why I'm going to that, I just want to answer your question properly so that we should understand. Yes. Therefore, there are three probably methods which the fibroid can be treated. Firstly, you can treat medically. And if you treat medically, it's really basically for pain or abnormal bleeding. Those patients are not prepared or planning to have pregnancy at that time. Then the second method as well, you can do surgical method. Surgical method, we divide it probably in 3 or 4. Now I'm going to go through each and every one. Laparotomy is a major operation which is done, and which is done. If you do that for infertility, we discouraged it for a number of reasons. If you do laparotomy and open hands-on and put your hands around the ovary, everything, you tend to give that woman a lot of adhesions. Actually, you can even expose that woman to infertility, trying to help. Therefore, it's very important to understand the reason why you come in. The standard and recommended method of surgery in this patient is laparoscopy, and laparoscopy is a short procedure, and then it's got less bleeding and less pain. Therefore, the dignity of women is also respected in that manner. Now, we've got the medical treatment. As I said, medical treatment interfere altogether with infertility. Therefore, on medical treatment, you cannot be pregnant because medical treatment has some effect. Firstly, it affects the inside of the womb, endometrium, make it thin. Whether it's oral contraception, which prevent ovulation, therefore that will stop you to getting pregnant. Whether you take something like Depo, that as well will do the same. Whether you take the GnRH analog, that will make the same. Prevent ovulation, thin the endometrium inside, and then we have difficulty in to get pregnant. Now, the other method, which is very common, I have to advise a lot of people because they think it's a new method. It's not a new method, however. It's uterine artery embolization. Uterine artery embolization, we really don't recommend it at all to a woman who wants to have children in the future. That method has got really a lot of side effects. I know the radiologists don't like that, but the fact that on literature you can just anywhere we don't recommend that woman should go that route. Fine. Let me explain exactly what is uterine embolization. It's basically whereby you go to the artery, we supply the fibroids, but you really cannot identify only that artery. Therefore, you're gonna block all the artery. It's like you're giving a heart attack to the fibroids. But during that process, the ovaries suffer. Therefore, patients who get that, they tend to have also blockage of the blood supply to the ovary. And then, really that become a problem. Therefore, you can push a woman early to, where their reserve has been actually hampered and they cannot, get pregnant. Secondly, uterine emboli as well, it affects the inside of the womb where the baby must sit. Whether you're doing IVF, whether you become pregnant naturally, the endometrium become not acceptable to the baby. Therefore, you tend to have a lot of miscarriage if you have done a uterine emboli. Therefore, then the other is really MRI, which is not that common, and then probably as well we don't recommend. Basically, I would say for every woman who would like to be pregnant, the basic treatment of a fibroid, it will be laparoscopic surgery and yes. Now, there are fibroids which are inside the cavity. There you have to decide, but most of them will remove them with a hysteroscopy. Therefore, hysteroscopy means we can look inside the cavity and look at the size of the fibroid. Usually all who are 4 centimeters and so we can then remove them. And there's a belief as well, and I have to say as well, probably even myself, when I was, still studying or at school, I used to say, fine, after you remove the fibroid, from the uterine cavity by hysteroscopy, you put an IUD or you put any, put a patient on contraception to prevent adhesions. That is not true. It doesn't work. It's not the way to go. It's just to really manage the patient naturally. There are now some gel which have been invented, but at the moment we don't know whether they will be helping, which you can inject after that. They claim that those gels will prevent the patient having adhesions. Now, I would like also to go ahead and talk about fibroid. Let's say you get pregnant with fibroids. Then the pregnancy with fibroid can be very complicated. People should understand as well. You can take the risk and say, no, I don't get, I don't want to do any surgery, I just want to get pregnant. You must know that also carries some risk. The first risk which you will have, depending on the size and where the fibroid is. If it's in the cavity, you likely, going to have miscarriage. You likely have, may have a preterm baby, which may be very difficult with you, for you. Secondly, if you've got fibroid as well, you're likely going to deliver by cesarean section. Right? Therefore, the last also very important thing people should realize, immediately you go as well with a huge fibroid and get pregnant, you're lucky to lose that uterus after you deliver. In other words, you may have severe hemorrhage, bleeding, and there's a risk you should take. And during that period, nobody will ever say, you know, I'm going to remove the fibroid and leave this woman. They will go and do hysterectomy. And that's what can happen. Therefore, you have to weigh both and get your gynae or your fertility specialist to really advise you what is the best. My approach in this is that not to harm a person with fibroid. It's better to remove them early, as you know, small as they are. Then the impact on the fertility of that woman is less. Therefore, that's my, a way of approaching fibroids. Rather than leave them to present with problem, and then you start acting on that, or the size become big, then you start working on them. Therefore, that's what I can, advise.
Oh. Wow, okay, doctor. What I definitely picked up from you is it's so important. I think we spoke about it the last time as well, that it's so important when you're dealing with something like this, that you're going to, if you're trying to conceive, I would so say, please go to fertility specialist, because his main function is always to try and keep you, to keep things intact. I would like to say, if I can put it that way, for you trying to conceive, and he would always have that in his mind, or she would always have that in the mind, that this patient still wants to conceive. So let's try and preserve whatever we can, and let's take the safest route when it comes to doing surgery on something like fibroids or cysts or anything in that matter.
Yes, I think you are correct. You are correct. Most of the time, people go and have some procedure really because of the fibroid, and most of the time it come either embolization, and then one patient I have also want to have kids, but now we're struggling because we can't even build the endometrium. But I have to go back and remove the fibroid and reconstruct the surgery. Most of fertility surgeons can do endoscopic surgery. They should be able to reconstruct the surgery. The uterus. They should be able to deal with fibroids, or whatever size, with the laparoscopy, because really, you've got less bleeding, as I said. You've got less pain for your patient, and patient can go early home. Therefore, it's very cost effective. Yeah.
Okay. I actually just wonder if you don't mind if we can just ask one or two questions, Doc. I saw a message from Wadia. There we go. Someone undergone a laparoscopy operation. Would the doctor be able to check whether the tubes were unblocked or not?
Yes. Then if you do laparoscopic surgery for fibroid, because, with a fertility specialist, that's the first thing, that you will have a good approach to that fibroid. For instance, we don't approach the fibroid and cut close to the tube, because you can damage the tube, or go and cut very close to the ovaries, because it can compromise the ovarian function as well. Now, during that process, you can as well examine and look at the tubes, and look at the ovaries, and look at all the structures around. Therefore, that's an advantage of laparoscopy, and therefore it's what we call now a conservative surgery for future pregnancy.
Okay. So we did a post yesterday and asked everyone if they have any questions for Dr. Moloi, especially on fibroids, please send it to us. And these were some of the questions that they asked. One of the ladies is 42, not ovulating, not getting periods. They were recommended to take Infertility and Provera, but still not getting any periods. Any advice?
Yes. This patient is 42, and then is not seeing any menstruation. I don't know whether you'd like to have children or not, but there are a few things. The advice I would really recommend is that you see the gynae, and the first thing is to really do a thorough evaluation of the pelvic, what means the uterus, and they look at the ovary, and look at the tubes, if they can see anything, something like hydrosalpingo, something like that. If they don't see it, to assume that the tubes are okay. And then there are blood tests, which are very important as well. Then you can go and do those blood tests, which we call hormonal profile. This is FSH, LH, and AMG, sort of. Then after seeing those things, that they are all equal and the womb is equal, that patient may even qualify for what we call a hysteroscopy, really to see inside the womb that that patient doesn't have Asherman syndrome or any adhesions there. Then if everything is okay on that side, then he can, if you want to be pregnant, then they can be put definitely on a form of treatment. Now, if everything is okay, the Provera is usually, as I said, there is a contraception. Therefore, basically, the patient will actually have the issue that she won't be able to menstruate. There's a difference if you do a challenge, Provera challenge in a person. In other words, the patient, you look at endometrium, you find out endometrium is thick, or a patient, for argument's sake, it's a patient with polycystic ovarian syndrome, and then she's got amenorrhea because she's got high estrogen, but she's not having progesterone. Then you do what is called progesterone challenge, which is strictly 10 days, and then stop and see what's happening. If nothing happened, it means now you have to go in and check what's happening in the patient.
Okay. And then someone that's got PCOS, what would you recommend, IUI or IVF?
If somebody's got PCOS, the first thing I'll check that the tubes are open, the uterus is fine, and then definitely it's got PCOS. And the other important thing, the partner's sperm count or semen analysis is okay. Then that patient can go very clean, and most of those, they become pregnant naturally. In other words, we just do what is induction, ovarian induction. Really, you give them something like Femara. And the other thing which is important, we're adding to this patient, especially all my patients who got PCO with nothing, they really, within 3 months, they get pregnant for a number of reasons. What I do, I give them Femara, combine it with metformin, right? And then follow them for about 2 months and see what they ovulate. Then in those small eggs, I'll see one growing, reaching 18 to 22 millimeter. Then explain, tell them that they should be close together for those 3 days. And majority, yes, they do. Yeah. Some they even get, although I have to admit, the other problem with this patient with PCO, they are vulnerable to have, twin pregnancy or triplets because they can ovulate two eggs at the same time. That's one problem which we have with them. We should especially should warn them that they have about 3 to 5% chance that they may end up with twin pregnancies. But really, most of them, besides weight, and I really have to warn people that you cannot say to those patients because they are overweight, therefore you cannot treat them. Try to encourage them to lose some weight, about using diet, exercise, and everything. Just 10%. If the patient's about 100, just moving to 90, you get good results. But they need a lot. It's not their fault to have PCO. PCO is genetic. In other words, if you can look and ask most of the patients, the mother, the sister, whatever, had the same problem. Therefore, they need to know. It shouldn't be like, you overweight, you're eating too much, go in and lose weight for 6 months and come back. That's not the treatment for PCOS.
Well, okay, thank you, doctor. And then I've got one more, says 38, PCOS, 4 failed IVF. Any advice?
Yes. Now, any advice? These patients have a 4 failed IVF. I don't know whether she had miscarriage or not. But then I'll answer in 2 ways. One of the important things in this case, she'll probably need what we call hysteroscopy to check inside the womb if there is nothing, which either polyp or a fibroid, and probably get a good gyne scan. Then secondly, this patient as well is more important as well to make sure that when they get pregnant, they're actually supported during the pregnancy. Know that the PCO, they've got high incidence of implantation failure because of the whole hormonal problem around it. Hence, you remember I talked of metformin and then Clomid. Actually, Clomid, sorry, we don't use it much. Femara is the best because Clomid can affect the endometrium. Therefore, those, if you use, most of the patient will go through naturally. Then the warning, it will be issued that implantation failure may be high or miscarriage. If it's a miscarriage, then we can do other tests to just check. Check as well. We know that most of the time we concentrate on the wife, or the female side. Check as well on the male side, the age, how was the sperm, and so forth, because that can contribute as well on this problem. Therefore, try to be holistic and look as much as you can. But hysteroscopy is probably the most important thing I'll say this woman should probably get. And then you can restart stimulation and change probably the method to using for stimulation in that patient.
Perfect. Thank you. Okay, one says that, okay, the lady asked, how can you minimize or shrink fibroids? But I think we already went through that. So we're just going to skip that one. Then can you conceive with fibroids in your womb? I think you already went through that one as well. You explained it quite nicely. And then this is an interesting one. So she's had 20 fibroids removed in October 2020. How long before it returns?
How long before the fibroid returns, or how long should she start to be pregnant? It's very important that a person, maybe I should stress, if you had fibroid and you had fibroid removed, fine, probably after 6 weeks or so, then you should be okay. But you should be, if you get pregnant, please inform your doctor who's going to deliver that you had fibroids removed and you need to deliver by cesarean section. Really don't ever take chances that, we had fibroids, therefore you can just go through pregnancy like anybody normal. Please don't do that, because most of the, uterine rupture, happen with people who had, especially multiple fibroid like she has.
Yeah, but what she's actually asking is how long before, because fibroids grow back, they return, or am I correct?
Yes.
So how long before you think fibroids would return after having all of that removed?
I can't tell how long it will, because already there are small ones which are growing. I can tell her that, depending on age, which I don't know, 6 weeks is enough. But if she's young and she's not, you can say she can wait until she get pregnant. I mean, she get a husband. But if she's, already above 30, 32, then 6 weeks is probably enough. And then with the doctor, they should work together to get to pregnancy, and then she should be treated as high-risk pregnant. But definitely, she probably will have some of the fibroids which were very small, which are still growing. And now there's actually been a debate about the fibroids and even, adenomyosis and so forth. Yes. Then some of the patient, or let me say, the fibroids and the issue, the problem we should get in the effort, it's very important that the doctor should explain to him and have a clear plan of, the next pregnancy. But fibroid will always grow. Therefore, immediately she start, heavy menstruation on a monthly basis, the small one will pop out quickly. Within 6 months, you'll have, even bigger ones. Therefore, as I said, the target of the treatment, it's whether you want to go to be pregnant, whether you want the fibroid removed because of pain, whether you want the fibroid removed because of abnormal or heavy bleeding. Therefore, those are the 3 parameters. But if it's for pregnancy, wait for 6 months and then try to get pregnant.
Okay, I've got the very last question. I'm not gonna keep you any longer. Somebody just asked, what is the difference between a polyp and a fibroid?
Yes, there's a big difference between a polyp and a fibroid. A polyp doesn't have muscles, therefore it's just an ingrowth of excessive growth of the endometrium lining. And however, it can become very big and cause abnormal bleeding. But the fibroid has got the muscle of the uterus, like it doesn't have only endometrial cell. It's got also the cells from the muscles of the uterus, and usually they are coiling. Yes. Therefore, that's the big difference between the two.
Yeah, I'm sorry to do this, Doc, but there's one very important question, and I think this woman really wants to ask this, is she was diagnosed with protein S. Is it a cause for concern for miscarriage? What can be done?
No. I think protein S with thrombophilia and so forth, a lot of people investigated, fine? And then we really don't have that straight association, fine? And we do, in a lot of patients, which probably will get a lot of miscarriage or getting a patient who cannot, get pregnant, and go we look for something like thrombophilia, protein S, all those kind. Most of the really studies, they don't really see the link between the two, fine? Therefore, I don't know at the moment whether she's struggling to be pregnant or not. But I think she can discuss with the gynae, and who have done all the better of tests and find out she have that, and probably refer, to endocrinologist to help, in managing this patient.
Oh, okay. Thank you very much, Doctor, for your time. I just have to commend you and always say that you've just got this way about you. It's like you're always just thinking of the women and putting them and their feelings and emotions and everything involved first, and considering them. And we really, really thank you for that, because a lot of time this journey, when you're going through trying to conceive, it's a very emotional journey, and sometimes a doctor doesn't understand that, but you make us feel that it's not our fault, and you are there to help the women. So thank you very much for that. If you guys want to get hold of Dr. Moloi, he's at the Joburg Fertility Centre in Johannesburg. Am I correct? In
Yes,
Gauteng, sorry.
yes. I'm in Gauteng. I'm
In Gauteng.
in Fourways, Santin.
In Fourways.
Yes.
So he is on Instagram, he's on Facebook. You guys can contact me that way, or you can actually DM me, or just pop me an email, and I'll send the details directly through to him. So thank you very much. And one of the ladies is saying thank you very much for the feedback. Really appreciate it.
Thank you.
Thanks. Have a great evening, Doc.
Thank
Great
you.
chatting to you.
Yes,
Bye.
thanks. Bye-bye.